Our next speaker is Dr. Robert Adams. Dr. Adams is Distinguished University of Neurology Professor at Medical University of South Carolina. He's also the 2013 winner of the Sherman Award. Dr. Adams will be speaking on rebuilding function after stroke.
Thank you, Bruce. I have some very special people that you're going to meet in a few moments, but first I'd like to ask how many people here besides Mike Chop were at the 1983 stroke meeting in Tampa, Florida? Anybody else? Oh, we've got a couple there. So that was held in the Hyatt Hotel, and there were, I think, 500 attendees, and there were almost 10 times that. But the organization's devious methods put everybody in the same room, which was their way of forcing the basic scientists, the neurologists, the neurosurgeons, the vascular surgeons, and the nurses all to be in the same room at the same time, or force them to slip out without being noticed. We've really come a long way, and one of the things that we're going to see today is some of the progress that's been made. At those early meetings, there was not a lot of recovery and rehabilitation sort of research, and that's one of the big changes that we've seen. Probably good in 1983. Honestly, we didn't know how far we had to go in 34 years. We were miles away from TPA, didn't know it. We were decades away from the systems of care and the kinds of multi-layered medical, endovascular, surgical care that we have today. It's really amazing that we have gone as far as we have. So today I want to talk a little bit about how do we recover and some of the technology that we're using. And until doctors and scientists like Dr. Chop teach us how to recover and rebuild the system from the inside out, we're going to be working from the outside in, working with things that are called exoskeletons that you're going to see demonstrated today, which are kind of a form of robots. Robot is a Czech word from the 1920s, and robotics has come a long way in industry, but it has not come so far in medicine, but you will see an example. Now, first off, I'm going to talk about video games. Just to give you an example, this is one of our doctors, one of our physicians. If you'll go back to that and click that, this is a game that she invented to assist therapy for shoulder problems. If we can get that to work. The shoulder problem, the shoulder has 6 degrees of freedom, so it's relatively simple. But after a stroke, the control is not very good. So she developed a game, a video game, where the patient has to, it's using Connect technology, where the person is trying to hit the duck and train themselves to get better at control of the shoulder. And if we can see it, here it is. So she's now, early after stroke, you can see how the shoulder is not working very well. And that's the little duck is up there that she's trying to hit. And I actually tried this, it's a little bit challenging. But this is an example, and you see how much better she gets after a little while. But this is an example of how video games and virtual technology, virtual reality, are being used to help people train sporadic limb. There's lots of these things. This is only one example. Now, after only 5 days, every time she hits it, she gets to make a sound. Now, I want to move from the shoulder to the hand. Now, I didn't know how many degrees of freedom the human hand has. As a matter of fact, I thought maybe it's like you can't count them. It's uncountable. When you think about all of the stuff that we can do. My colleagues in the College of Health Professions told me, Dr. Najin told me that there are 27 degrees of freedom, which means that the hand is extremely complicated. So I'm going to give you an example of an upper extremity orthosis that helps restore hand function, and this is called a MyoPro. It's FDA approved under a 510 exemption, and it uses residual muscle activity, gets EMG surface signals, and in that way it's used to control the assistive robotics that you get. So if we can get this one to go. Patty. Yeah. Have to be careful.
My name is JJ. I had a stroke in 2013. I left my left side a little bit immobile. The MyoPro brace has had a pretty good impact on my life because it's helped me where I could raise my arm, use my hand better where I couldn't do it before. With the G, what I couldn't do before, I couldn't as far as cooking on the stove was impossible. Most challenging is cooking is holding the pan in the right spot and using your other hand to either flip your food or turn it and keeping the pan steady so it won't slide off the stove on you. Well, the G has really been fantastic because I couldn't open my hand at all. It's helping me maneuver not only my hand, but my fingers and my thumb where I couldn't do that at all, period. That was just out of the question. Mostly being paralyzed, you can't grab things like you usually would do with both your hands and pick it up.
So this is an example of how you can work with the upper extremity. Now, robotics are used in intervention and physical therapy in the studio, but they can also be used for independent activities. So right now I'm going to show you in Indigo, and I want you to meet Patty Weiss, who's going to come over here and walk with this, and Claire Hardigan. They're here at the conference, and she's using this device, which is triggered not by EMG, but by residual movement in the muscles. This is a unit that's about 20 pounds. And this is FDA approved for spinal cord injury, and it's being currently tested in stroke. Turn around and come this way if you would. Okay. We get her on camera.
Turn and walk. That's it.
Yeah.
I think I was probably blocking people.
Mm-hmm.
Okay, so
Probably am too. So tell me a little bit, Patty, how long have you used this the device?
About a year.
Yeah, so Patty's part of our clinical trials going on with stroke, and it's been a year, but probably the number of times you've been in the device has been maybe 15 or 20.
Right.
According to whatever she was there for.
Yeah.
Yeah.
And I understand when I met you yesterday that you haven't fallen and you've learned to use it pretty well. Is that right?
Yes, it's it's a lot of fun to walk in this. I don't have to work as hard. I don't tire as easily.
Well, thank you very much. And I think you came from Georgia to be here. One of her personal goals was to participate in research, and she's been in, I think, about 5 studies, so we thank her for that. And this also, I could explain a little bit, while Jess is working her way over here to us, that this unit has 2 real modes. This is in the therapy mode, which is triggered, but when it's used in the spinal cord injury mode, where there's no residual muscle activity, it's really a forced step pattern that the generates. Stroke has its problems, but many times we do have residual activity to work with the exception of the case I'm going to talk about at the end, which is the locked-in syndrome. So this is now the Exo. She's coming over here. She's traveled from San Francisco to be here and to demonstrate this device, which actually is the robotic exoskeleton, is FDA approved both for use in spinal cord injury and in stroke. And it's also triggered in this mode with residual activity. Is that right? Yes. Right. And this is Matt Knowles. This also has a sort of an automatic program for spinal cord injury. Is that right?
Yes. Let me just get past these.
Okay.
Yeah, big step. Yeah, big step. There you go. Nice. Big step. Yeah, one more.
Wonderful. Yeah. So Jess, thank you for coming.
No problem.
From San Francisco?
Yes.
So how long have you used this, the Exo?
5 months.
And how's that going?
Very well. It's exciting.
Well, I can't tell you how important it is for you to be here today, and thank you very much. And if you guys could sort of demonstrate it, kind of work your way around, because this is what it's important for us to realize and to thank these individuals and these companies. And it's good to know that not all of the engineers are working in entertainment and in video games, but many of them are working on devices to help our patients really improve their activity. And this company is working on a device that can be taken home. Currently, the Myo arm device can be taken home, but both these devices you're seeing here are really used in therapy, but eventually people will be going home with robotic exoskeletons. And in doing so, they should be able to rejoin their communities with a lot more ease. So thank you again. We appreciate you being here. Give them a good hand. Thanks a lot. Thanks. So finally, and we'll get to see our volunteer use these devices, and you can see these on the floor of the exhibit, but I wanted to bring them here because the people that will see this afterwards, hopefully people will watch these presentations afterwards, will not be able to see them, and I think it's important. I remember when I was a grad student and I was trying to decide what to do, whether to go from engineering to medicine. I was particularly impressed by a story of a neurosurgeon named Jose Delgado. Who's heard of Jose Delgado? Mike has, right. So the story was that he was a Spanish neurosurgeon who got into the bull ring, whatever you call it, where you have bullfights, and he got in front of a raging bull and stopped the bull by pushing a switch that stimulated electrodes that blocked the amygdala, the rage reaction of the bull. And you can go on YouTube and see this, the bull charging, and all of a sudden stops and turns around and looks confused. Now, whether he was actually doing that without a safety net, I don't know, doesn't matter. Made a big impression. Would be nice if we could have some young people here that would take some of what we're seeing here now and would go further with it. I was started off as an engineer. I worked for a year in the spinal cord injury unit and then went into more traditional stroke career. But lately I've gotten more interested in this field, although mostly that's to encourage young people to go into it. I can tell you firsthand, after spending a year on the spinal cord injury unit, how difficult and challenging that is. Now, no talk like this would be complete unless I said something about the issue and the ability for us to acquire signals directly from the brain to control external devices. Eventually, we want to have all that done seamlessly, like before injury, but that's going to be a while. So this BrainGate program has been going on for about 20 years, and I'm going to show you a little bit of video from that. But essentially, it's getting signals from the brain directly with what's called an ECOG, an extracortical electrode. Now, the problem here is, of course, that it would be nice if you could get the signal from the surface. But the problem with that is that the skull and the scalp filters out a lot of the more interesting signals. It's kind of like you're on the outside of a factory building, a noisy factory, and you're trying to hear a conversation in the break room between two people. It's very hard. It's a very hard signal-to-noise problem. You get past that if you go inside and get on the cortex, and then you get much better signals, but then you've still got a lot of trouble sorting those signals out. And you have to process, you have to acquire the signal, then you've got to somehow figure out what is the intent of the person. What are they intending to do? And reproduce that signal consistently and give it and transfer it to the robot. So what we'll see here now, if we get this going here, this is Lee Hochberg, who's a neurologist, one of the people in BrainGate.
In this paper, 2 people with tetraplegia, that is 2 people who were unable to move their arms or their legs in any functionally useful way, were able to control a prosthetic or a robotic arm simply by thinking about the movement of their own paralyzed hand. And they did that using the investigational BrainGate neural interface system. So they thought about using their own arm and hand as though they were reaching out themselves with their own limb, and the robotic arm moved much the way their own arm would have moved. One of the long-standing questions, not only in neuroscience, but in neurorehabilitation, is whether the cells in the motor cortex and other parts of the brain, whether they continue to function the same way years after that original injury.
It is possible for people to use their thoughts to control devices, either a computer or a robotic arm. And the way that happens is that we implant a tiny sensor, just about the size of a baby aspirin, just into the surface of the brain, and that sensor pick up the electrical impulses from a bunch of neurons. And each of those little neurons are like radio broadcast towers putting out impulses. And when they get to the outside, a computer translator converts the pattern of pulses into something that is a command.
One of our participants was able to do something that, when all of us saw it for the first time, gave us all pause. She reached out with the robotic arm, she thought about the use of her own hand, she picked up that thermos of coffee, brought it close to her, tilted it towards herself, and sipped the coffee from a straw. And that was the first time in nearly 15 years that she had picked up anything and been able to drink from it solely of her own volition.
There was a moment of true joy, true happiness. I mean, it was beyond the fact that it was an accomplishment, I think an important advance in the entire field.
So I want you to remember that smile, and remember that even though these are small gains, they may mean a lot to our patients who haven't been able to use their body in the way that we all take for granted. How many of you have read the book, The Diving Bell and the Butterfly? I'm sure some of you have. The story of Jean-Dominique Baudy, who was in the prime of life and had a brainstem stroke, spent, I think, over a year writing a book about it, that book, with only blinking his left eye. He took about 2 minutes to signal out a word. And unfortunately, he died shortly after the book was published, but it's a terrific, terrific book to read. So I want to thank our individuals and their support people and my fellows, Suzanne and Pratik, for them, what they did to come here and be part of this talk. So thank you very much, and thank you.